I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we are going to deal about the cancer cervix. So in the previous module, we dealt about the cervical intraepithelial neoplasia and the various treatment modalities and diagnostic approaches with respect to cervix. So now we have come to the conclusion of cervix, where we'll be dealing about the oncology in cervix, and that is all about the cancer cervix. Right, so let's begin with the cancer cervix. So I have divided this cancer cervix topic into two parts. In the first part, we'll be discussing about the every theoretical important features of cancer cervix, and in the part 2 we'll be discussing about the investigations and management, that is the treatment options. Right, in the first module itself, we are going to discuss about the staging of cancer cervix also. So this module is going to be a little bit lengthier, so I would probably suggest you to watch this module in a speed of about 1.5x. Is that clear? Okay, so let's start with the module. So which is the most common cancer in the world? So in females, the most common cancer in the world, in the order of decreasing frequency, it is going to be the breast cancer, followed by the colorectal cancer, and then the lung cancer. The fourth is going to be the cancer cervix, followed by the endometrial, ovarian, and the skin cancer. Is that clear? Okay, still breast cancer constitutes to be the most important cancer, the most common cancer in the world as well as in India, and it is also leading to significant mortality. Right? Okay, so now let's get inside the cancer cervix. So what are the risk factors for cancer cervix? So as we all know, human papilloma virus infection is the most important risk factor, which is responsible for around 90% of the cases of cancer cervix. Because HPV infection is actually a sexually transmitted infection, right? Through sexual transmission, this infection is going to be acquired. And when does a female is going to be sexually active? She is going to be sexually active most probably during her reproductive age group years. So therefore, HPV infection occurs more commonly to the reproductive age group year. So for that reason, we have to start screening right from 21 years or right from 30 years in all the females in order to detect this HPV infection earlier and treat it properly. Right? Okay. So the risk factors are the HPV infection, which is the most common risk factor, contributing about 90%, followed by multiple sexual partners. Any female with multiple sexual partner, that is also a risk factor for cervical cancer. And early age of first coitus, that is, a female is getting sexually active at less than 18 years of age, right? So that is going to be a risk factor for cancer cervix. And then early age of first conception, any pregnancy which is going to occur in a female at less than 18 to 20 years of age, that is also probably a most important risk factor in the causation of cancer cervix. And then any patient with immunodeficiency, HIV positive status, as we have already discussed that HIV positive females are at increased risk of cancer cervix when compared to the normal population females. Right, so HIV positive status and immunodeficiency, and any female with multiparity was given birth to more than equal to 2 or more childs, right? So multiparity, and then poor socio-economic status, smoking is also a risk factor for squamous cell carcinoma, right? So similarly, smoking is also a risk factor for cancer cervix. And then oral contraceptive pills, that is OCPs, which we commonly use as a birth spacing method, right? In order to delay the conception, every other female who wants to delay the conception, they are going to use this oral contraceptive pills. But it is a reversible risk factor. What do you mean by reversible risk factor? It means that if a female is going to discontinue the usage of oral contraceptive pills in a period of about few years, the risk of developing cancer cervix is going to be reversed, and she is going to have the risk as every other normal female who is not using the oral contraceptive pills. Is that clear? So HPV infection most common, followed by multiple sexual partners, early age of first conception, early age of first coitus, HIV positive females, immunodeficient state, multiparity, poor socioeconomic status, smoking, and oral contraceptive pills. So these are the risk factors of cancer cervix. So if you get any question about the cancer cervix, let's say for example you get an essay about the cancer cervix which I got probably in my university examination, you have to write starting with the risk factors of cancer cervix. Okay? Yes. So now let's jump inside the cancer cervix. So how many years does it take to develop the cancer cervix? So cancer cervix is not some magic that is going to develop within a period of a night, or let's say for about 24 hours. No, it is not going to happen like that. So what actually happens is that we all know that dysplasia. What do you mean by dysplasia? Abnormal cell growth, proliferation and differentiation, right? Abnormal cell growth in terms of proliferation and differentiation, that is called as dysplasia. That is, the cells are going to develop in an abnormal fashion, right? So dysplasia leads to right? We all know that coilocytic change happens in every squamous cells because of dysplasia, right? If it is going to happen in a hastened manner, it is going to result in cancer cervix. So always this dysplasia is going to result in a precancerous condition. Precancerous condition is a condition where it is not a cancer, but it is the previous stage of the cancer. In a few years of progression, it will develop into a cancer, which can be either a cancer in situ or an invasive cancer. So as we all know, the cervical intraepithelial neoplasia, which is a precancerous condition of cancer cervix, it will take about a period of 5 to 10 years or more than 10 to 15 years to develop into cancer cervix. So this cancer cervix is not something which is going to develop over the night. It will take a period of about 10 to 15 years, right, to convert from cervical intraepithelial neoplasia 1 to 2 to 3, and then to come to in situ, and then it becomes invasive cancer cervix. So what do you mean by cancer in situ? Cancer in situ is where the cancer is going to restrict it to the cell of its origin. It is not going to spread beyond the cell of origin, that it is not going to spread to any other tissues. It is going to be restricted to only those cells where it has been originally originated. So that is cancer in situ. Whereas invasive cancer means it is going to spread to every other surrounding tissues as well. Right? Okay. So now we are getting inside the cancer cervix. So there are two most common types of cancer cervix. The most common is the squamous cell carcinoma, and the second most common is the adenocarcinoma. So squamous cell carcinoma is the carcinoma which arises from the squamous cells. Adenocarcinoma is the carcinoma which arises from the columnar epithelium, right? So squamous cell carcinoma arises from squamous epithelium. Adenocarcinoma arises from columnar epithelium. Right. So where does this squamous cell carcinoma occurs more commonly? More commonly, squamous cell carcinoma occurs in the transformation zone or the squamo-columnar junction. What is the transformation zone? The area of the cervix between the old squamo-columnar junction and the new squamo-columnar junction. So as you can see here, this part is the transformation zone between the old and the new squamo-columnar junction. Right? The squamous cells are lined in which part? They line the ectocervix or the exocervix, whereas the columnar cells, they line the endocervix. Clear? So adenocarcinoma arises more commonly from the endocervix. Right? Okay. So squamous cell carcinoma, most common site is transformation zone or the squamo-columnar junction. Adenocarcinoma, the most common site is the endocervix. Okay. So what is the ideal age group where cancer cervix occurs more commonly? Cancer cervix occurs more commonly in the younger age group females, that is in the reproductive years. It is because of HPV infection as the most common risk factor or the most common causative factor in the causation of cancer cervix. About 90% of the cases, the causative factor is HPV infection. And HPV infection is getting transmitted from one person to another through sexual. So it is a sexually transmitted infection. Since it is a sexually transmitted infection, most commonly it is going to acquire in a female who is sexually active. So who is actually sexually active? The reproductive age group females are sexually active. So younger age group females who are in the reproductive age group years, since they are at risk of the HPV infection, the most common age group for cancer cervix is the younger age group, reproductive age group female, where the median age for cancer cervix is around 50 years. is around 50 years. The median age for cancer cervix is around 50 years, but the most common age group for cancer cervix is the younger age group. To be more precise, it is the reproductive age group females. Right, so since it is more common in the reproductive age group or the younger age group female, therefore the ACOG, that is the American College of Obstetrician and Gynecologists, as well as the World Health Organization, they told us that you have to start screening for cancer cervix in a female from, ACOG tells to start the screening for cancer cervix from 21 years, whereas WHO tells to start the screening for cancer cervix from 30 years, right? Okay. So now with discussing about this, we are going to come to the next session of cancer cervix. So we discuss about the cancer cervix types, squamous cell carcinoma, adenocarcinoma, and which age group female it occurs more commonly, where does it occurs more commonly, etc. Now, let's say for example, a female is a case of cancer cervix. How is she going to come to you to the hospital with complaints of? So the first complaint any female with cancer cervix is going to come is complaints of irregular bleeding. Irregular bleeding is defined as in between the normal menstrual cycle, a female is going to experience bleeding. So between the normal menstrual cycle, the female is going to have bleeding. So it is an irregular menstrual cycle. So irregular bleeding is the most common complaint of cancer cervix. But which is the most specific complaint in a patient of cancer cervix? The most specific complaint in a patient of cancer cervix is postcoital bleeding. Always please remember postcoital bleeding. If you hear the term postcoital bleeding, the most common cause is going to be cancer cervix. Right? Postcoital bleeding, the most common cause is the cancer cervix. So the most common complaint in a patient of cancer cervix is irregular bleeding. That is, in between the menstrual cycle, the patient is going to have irregular bleeding. So since the cycle is very irregular, it is called as irregular bleeding. Between the menstrual cycle, the patient is going to experience bleeding. So the most common complaint is irregular bleeding, and the most specific complaint in a patient of cancer cervix is postcoital bleeding. After sexual intercourse, the patient is going to have bleeding. So after the act of coitus, the patient is going to experience bleeding per vagina. Therefore, it is called as postcoital bleeding. Coitus means intercourse. So postcoital bleeding is the most specific symptom of cancer cervix. So whenever you get to know any terms in any scenarios such as postcoital bleeding, you have to keep a differential of cancer cervix. Right? The most specific complaint is postcoital bleeding. Now, what is the algorithm? The algorithm is that, let's say for example, a female of 42-year-old, she's coming with the complaint of postcoital bleeding. What will you do? For any female with complaint of postcoital bleeding, if she belongs to reproductive age group years, do UPT. If it is negative, ask the patient to please pass the urine and come with the glove. So once she comes to you, do the per speculum examination, where you're actually going to put the speculum and examine her. So once you're going to put the per speculum and examine her, what can be the results? It can be either normal, it can be either abnormal cervix, or there could be any suspicious of malignancy. Any suspicion could be present. Right? Okay. If on per speculum examination, everything in the cervix is going to appear very normal, you just have to do the screening. Right? Since she is the age of 42-year-old female, you have to screen the patient for cancer cervix. So always screening is done with pap smear in OPDs. So do pap smear and see what is the report of pap smear. If it comes to be negative, do the colposcopy. Is that clear? Initially, you have to see whether the patient is belonging to reproductive age group. If she is belonging to reproductive age group, do the urine pregnancy test. If it is negative, put the per speculum and do the examination. Right? On post-speculum examination, if the cervix is going to appear normal, just do the screening for cancer cervix, do the pap smear, and depending upon the report of the pap smear, you have to do the next investigation. Right? If the report of the pap smear is going to be LSIL, HSIL, or adenocarcinoma in situ, something like that, you have to follow up it with the colposcopy. Right? If pap smear tells to be atypical squamous cells of unknown significance, LSIL, HSIL, adenocarcinoma in situ, you have to report it with the colposcopy, since pap smear is only a screening test as well as colposcopy is a diagnostic test. Clear? Yes. If the cervix is going to look abnormal, it is a thick cervix, it is an indurated cervix, a barrel shaped looking cervix. If the cervix is abnormal, if you are going to see some lesions, any lesions or ulcers or mass being present in the cervix, you have to do punch biopsy. Do punch biopsy. Is that clear? If the cervix is abnormal, if you are going to see any lesions, ulcers or any mass, take the biopsy, because you're not going to screen the patient for cancer cervix. Since you are seeing some mass in the cervix, you take punch biopsy from that part. If there is any suspicion of malignancy being present, now you have to do biopsy. It could be a punch biopsy, and you also need to do endocervical curettage. Right? Because for suspicion of malignancy, you have to rule out the both squamous cell carcinoma, which is arising from the squamous cells, and you have to rule out the adenocarcinoma, which arises from the columnar cells of the endocervix. Right? If the cervix is going to look normal, do the screening test with pap smear. If pap smear report is going to be LSIL, HSIL or anything, confirm it with the colposcopy, that is the diagnostic test. If the cervix is looking abnormal, if any lesion is present, any ulcer, any mass is present, please take the punch biopsy. If there is any suspicious of malignancy, you have to take the biopsy as well as you have to do the endocervical curettage, because since the suspicion of malignancy could direct you towards either squamous cell carcinoma or the adenocarcinoma of the cervix. Clear? Okay. Now, so having discussed about the further details of cancer cervix, now we are moving to the route of spread of cancer cervix. So always please remember, the most common route of spread of cancer cervix is lymphatics. Lymphatics is the most common route of spread of cancer cervix. So please keep in mind that cancer cervix spreads through what route? It spreads through lymphatic routes. Cancer cervix is lymphatic. Cancer cervix is lymphatic spread. So as you all know, the lymphatic drainage of the cervix, that is from the paracervical surrounding the cervix and parametrial surrounding the uterus. So paracervical and parametrial lymph nodes, these will drain into the obturator group of lymph nodes. From the obturator lymph nodes, the lymph is going to drain into the internal iliac and the external iliac and the common iliac. Through the common iliac, it will drain the para-aortic group of lymph nodes. What is the lymphatic drainage of cervix? Paracervical or parametrial? Most probably it is paracervical, followed by the parametrial. It will drain into the obturator group of lymph nodes. From the obturator group of lymph nodes, the lymph will drain into the internal iliac, external iliac and the common iliac group of lymph nodes, and from the common iliac, the lymph will drain into the para-aortic group of lymph nodes. Right? And there is also one lymph node you have to remember, that is the rectal lymph nodes. How rectal lymph nodes is connected to the lymphatic drainage of cervix? That is because from the lymphatics from the posterior cervix will drain lymphatics from posterior of cervix will drain into the rectal lymph nodes via the uterosacral ligaments. Is that clear? Lymphatics from the posterior wall of the cervix will drain into the rectal lymph nodes via or through the uterosacral ligaments. So through the uterosacral ligaments, the lymphatics from the posterior cervix will drain inside the rectal group of lymph nodes. So what are the lymphatic drainage of cervix? It is the paracervical, parametrial, obturator, internal iliac, external iliac, common iliac, para-aortic group of lymph nodes, and the rectal lymph nodes. So, as we all know the lymphatic drainage of cervix now, if the lymphatic spread is going to be the most common route of spread of cancer cervix, then therefore all these group of lymph nodes can get involved through the lymphatic drainage, right? Since it has a lymphatic spread, since the cancer has a lymphatic spread, therefore this cancer can spread through the lymphatics through all the root where the lymph nodes of cancer cervix are going to drain. Is that clear? Yes. So similarly, paracervical, parametrial, obturator, internal iliac, external iliac, common iliac, para-aortic, and the rectal lymph nodes have to be looked upon here because of the fact that from the cervix, the lymphatics are going to drain into these groups of lymph nodes. So since cancer cervix has the most common lymphatic spread, the cancer can therefore spread from the cervix to these groups of lymph nodes. Yes. So therefore, the lymph node dissection, if done, it has to involve all these groups of lymph nodes. Yes, if the lymph node dissection, lymphadenectomy has to be done in a case of cancer cervix, it has to involve all these groups of lymph nodes, since all these groups of lymph nodes are involved in the lymphatic drainage of the cervix. Yes? Okay. Now, superficial inguinal lymph node. Now you tell me, superficial inguinal lymph node is linked to the lymphatic drainage of cervix? No. Superficial inguinal lymph node is not connected to the lymphatic drainage of the cervix. But in case, if you get to know that the superficial inguinal lymph node is positive, yes, if the superficial inguinal lymph node is positive in a patient of cancer cervix, what does it mean? Does it mean that the cancer from the cervix through the lymphatics it has involved the superficial inguinal lymph nodes? No, it cannot involve the superficial inguinal lymph nodes. If the superficial inguinal lymph node comes to be positive in a patient with cancer cervix, it means there is distant metastasis. Distant metastasis. What do you mean by metastasis? Metastasis is actually the spread of the cancer, right? Distant metastasis means it has spread to a site far away from the original site of the cancer. That is all about distant metastasis. So, if superficial inguinal lymph node is involved in a patient with cancer cervix, it is through the distant metastasis only and not through the lymphatic drainage. Is that clear? Okay. So, distant metastasis is given a stage in cancer cervix, and that is stage 4B. Stage 4 in cancer cervix means metastasis. Stage 4B means distant metastasis. Then what is stage 4A? 4A is regional metastasis, such as the surrounding region. Let's say the bowel or the bladder metastasis is the regional metastasis, which constitutes stage 4A. Stage 4B means distant metastasis, such as the superficial inguinal lymph nodes. Clear? Yes. So stage 4B is distant metastasis. Superficial inguinal lymph nodes. So one thing which is a common feature between the cancer endometrium, ovary and the cervix, endometrium, ovary and the cervix, is the involvement of superficial inguinal lymph node is considered to be stage 4B. Right? Clear? Involvement of superficial inguinal group of lymph nodes in a patient with cancer endometrium, cancer ovary, cancer cervix is considered to be stage 4B. Clear? Yes. Similarly, when there is involvement of pelvic group of lymph nodes in a patient with vulval cancer, it is stage 4B. Clear? Is that clear, students? Right? So whatever we have discussed until is the pelvic lymph nodes. And superficial inguinal lymph nodes cannot be involved in a patient with cancer cervix through lymphatics. If it comes to be positive, it is through the distant metastasis. Similarly, if in a patient of vulvar cancer, if the pelvic lymph node is going to be positive, then it suggests that it is stage 4B. So stage 4B in a patient with cancer, ovary, endometrium and cervix a superficial inguinal lymph node involvement. Whereas stage 4B in a patient with vulvar cancer, it is all about the pelvic lymph node involvement. Clear? Superficial inguinal lymph node involvement is stage 4B in cancer, cervix, ovary and endometrium. Pelvic lymph node involvement in a patient with cancer cervix is stage 4B. Clear? Yes. Okay, so now having discussed about the lymphatic spread, now we are going to discuss about the hematogenous spread. Hematogenous spread is the spread of the cancer through the blood, and this is actually less common when compared to the lymphatic spread, and it constitutes about 12%. So what are the routes which are involved in the hematogenous spread? Even though it is less common, you have to know about that, right? So it is actually the lungs, followed by the ovary, followed by the liver, followed by the bone, right? So lungs, hematogenous spread, lungs, ovary, liver and bone. Hematogenous spread is very less common. It accounts for only 12% of cancer spread, but lymphatic spread is the most common route of spread of cancer cervix, right? Okay, so now we are moving to the staging of the cancer cervix. So with respect to staging of the cancer cervix, the most important prognostic factor, we are going to have something called as the prognostic factor in every cancer we are going to discuss. As far as cancer cervix is considered, the prognosis of the patient, the outcome of the patient is decided upon the staging. The stage is more concerned than the lymph node involvement, right? Lymph node involvement is just secondary, but the stage of the disease is more important when it comes to cancer cervix. So the staging of cancer cervix is given by the FIGO. FIGO stands for Federation of International Obstetrics and Gynecology. So FIGO gave the staging of cancer cervix. So we have divided the stages into 4. Stage 1, stage 2, stage 3 and stage 4. Right? Stage 1, 2, 3 and 4. What is stage 1? Stage 1 is the cancer is limited to the cervix. While stage 2 is that the cancer has spread to the upper 2/3 of the vagina. Whereas stage 3 is the cancer spread to the lower 1/3 of the vagina. We have divided the vagina into upper 2/3 and the lower 1/3. Right? So the upper 2/3 spread is stage 2. The lower 1/3 of the vagina spread is stage 3. And metastasis is always stage 4. Clear? Stage 1 is cancer is limited to the cervix. Stage 2 is involvement of upper 2/3 of vagina. Stage 3 is involvement of lower 1/3 of vagina. Stage 4 is metastasis. Clear? Okay. So before discussing about the stages, I want you to remember one thing. And that is that, please remember this formula for me. And that is 1B3 plus 2A2. 1B3 plus 2A2. 1B3 plus 2A2. Clear? Okay. So now let's start discussing about the stages. We have stage 1, 2, 3 and 4. Stage 1 is where the cancer is limited to the cervix. There is no involvement of any other part other than the cervix. Right? So stage 1 is also all about the limitation to the cervix. So cancer is basically limited to the cervix in stage 1. So we have basically divided the stage 1 into 1A and 1B. Right? Stage 1A and 1B. So we have further divided stage 1A into 1A1 and 1A2. Similarly, 1B is divided into 1B1, 1B2 and 1B3. Right? 1A1, 1A2, 1B1, 1B2, 1B3. Stage 1A is all about microinvasion. Stage 1B is all about macroinvasion. Microinvasion is less than 5 mm deep. Macroinvasion, that is stage 1B, is more than 5 mm deep. So when we speak about stage 1A, it is all about microinvasion. When we speak about stage 1B, it is all about macroinvasion. So 1A1 means it is less than 3 mm deep, whereas 1A2 means it is 3 to 4 mm deep. 1A1, 1A2. 1A1 is less than 3 mm deep. 1A2 is 3 to 4 mm deep. Right? Okay. So stage 1B is macroinvasion, where the invasion depth is going to be more than 5 mm. So we have divided 1B into 1B1, 1B2 and 1B3. So please remember, when we discuss about the B, we always discuss in terms of the size of the tumor. We are not going to discuss it as of the invasion. We are going to discuss it with respect to the size of the tumor. So 1B1 is when the size of the tumor is less than 2 cm. 1B2, the size of the tumor is more than equal to 2 cm, and 1B3 is when the size of the tumor is more than equal to 4 cm. Less than 2 cm, more than 2 cm. 1B3 is all about more than equal to 4 cm. Clear? Okay. So now we are going to discuss about the stage 2. Stage 1 is micro-invasion, stage 1A is micro-invasion, stage 1B is macro-invasion. We had 1A1, 1A2, 1B1, 1B2 and 1B3. 1A1 is the invasion is less than 3 mm. 1A2, it is 3 to 4 mm deep. 1B1 is when the size of the tumor is less than 2 cm. 1B2 is when the size of the tumor is more than equal to 2 cm. And 1B3 is when the size of the tumor is more than equal to 4 cm. Okay, what is stage 2? Stage 2 is involvement or the spread of the cancer cervix to the upper two-thirds of the vagina. Okay, so stage 2 is further divided into stage 2A and 2B. Similar to 1A and 1B, it is stage 2A and 2B. Similar to stage 1A1 and 1A2, we have stage 2A1 and 2A2. But we don't have any subdivision for 2B. We had 1B, we had 1B1, 1B2 and 1B3. But in 2B, we don't have any subdivisions. We have subdivisions only for 2A1, 2A, that is 2A1 and 2A2. 2A1 is when the parametrium is involved or not. So 2A and 2B, the differentiating feature is the parametrium involvement is there or not. If the parametrium is not involved, it is stage 2A. If the parametrium is involved, it is stage 2B. Clear? 2A is when the parametrium is involved, 2B is when the parametrium, 2A is when the parametrium is not involved, and 2B is when the parametrium is involved. 2A, 2B, 2A means parametrium is not involved, 2B means the parametrium is involved. Parametrium is all the fat and the fibrous tissue, right, which is surrounding the uterus and which is connecting to the pelvic side wall, right? Between the uterus and the pelvic side wall, whatever fibrous and fatty tissue is present, that is the parametrium. Let me give a diaphragmatic representation here. This is the pelvic side wall and this is the uterus. So all the space between these two is the parametrium, right? So this part is the parametrium. This is going to be the cervix, the vagina. So when the parametrium is not involved, it is stage 2A. When the parametrium is involved, it is stage 2B. Clear? Okay. So in 2A, we have subdivisions as 2A1 and 2A2. So 2A1 is when the size of the tumor is less than 4 cm. 2A2 is when the size of the tumor is more than equal to 4 cm. Clear? 2A1, 2A2. Parametrium is not involved in 2A. 2A1 is when the size of the tumor is less than 4 cm. 2A2 is when the size of the tumor is more than equal to 4 cm. Then what is stage 2B? 2B is when the parametrium is getting involved. Parametrium involvement is seen in stage 2B of cancer cervix. Clear? Okay. Now stage 3. So stage 3 is when the lower one-third of the vagina is involved. When the lower one-third of the vagina is involved, it is stage 3. So in stage 3, we have stage 3A, 3B, 3C. Right? In stage 3, we have stage 3A, 3B and 3C. We don't have any subdivisions in stage 3A and 3B, but we have a subdivision in stage 3C. That is 3C1 and 3C2. Right? So when we discuss about stage 3, we are going to discuss about the pelvic side wall involvement. Is that clear? When we are discussing about the stage 1, we were discussing only the involvement of the cervix. Right? The cancer is limited to the cervix. When we discuss about the stage 2, we were discussing about the parametrial involvement. So now we are going to discuss about stage 3. In stage 3, we are discussing about the pelvic side wall involvement. Right? Stage 3 is all about the lower one-third of the vagina is involved, and depending on what we are going to subdivide it, depending on the involvement of the pelvic side wall, we are classifying the subdivision of stage 3. 3A, 3B and 3C. 3A is when the pelvic side wall is not involved. 3B is when the pelvic side wall is getting involved. When the pelvic side wall is getting involved in cancer cervix, it is stage 3B. Stage 3B, pelvic side wall is getting involved. You can also have hydroureter or hydronephrosis as a feature. What is hydroureter and hydronephrosis? It is when the ureter is going to get bulged with the fluid, that is hydroureter or the hydronephrosis. So involvement of the pelvic side wall, if it happens, if there is going to be involvement of the ureter which is bypassing the parametrium, right? So this is going to be the ureter which bypasses above the parametrium. If there is going to be involvement of the ureter, there is going to be hydroureter or hydronephrosis. So pelvic side wall involvement is seen in stage 3B and hydroureter or hydronephrosis is also seen in stage 3B. Clear? Okay. So what is stage 3C? 3C is all about the lymph node involvement. So when does lymph node involvement occurs in staging of cancer cervix? It occurs in stage 3C. In stage 3C, we have two subdivision, 3C1 and 3C2. C1 is when the pelvic lymph node is getting involved. 3C2 is when the para-aortic lymph node is getting involved. Pelvic lymph node 3C1, para-aortic lymph node 3C2. So stage 4 is all about metastasis. 4A, 4B. 4A is all about regional spread. Regional is surrounding region. There is bowel or bladder involvement. 4B is all about the distant spread or metastasis or the involvement of the superficial inguinal group of lymph nodes. Clear? So this is all about the staging of cancer cervix. So just a gist I'm going to give you. So staging of cancer cervix can be divided into 4 stages: stage 1, 2, 3 and 4. Stage 1 is where the cancer is limited to the cervix. Stage 2 where the cancer is involving the upper 2/3 of the vagina. Stage 3 is where the cancer is involving the lower 1/3 of the vagina. Stage 4 is all about the metastasis. In stage 1, we are going to divide it into 1A and 1B. 1A is all about microinvasion and 1B is all about macroinvasion. 1B, the further subdivisions are classified based on the size of the tumor. Similarly, when we discuss about stage 2, we are dividing the stage 2 into subdivision of stage 2A, 2B based on the involvement of the parametrium. Stage 3 is when there is involvement of the lower 1/3 of the vagina, and the further subdivision of stage 3 is decided when the pelvic side wall is involved or not. If the ureter, which bypasses the parametrium, if the ureter is involved, it is hydroureter or hydronephrosis along with the pelvic side wall involvement, right? So when the pelvic side wall involvement is seen, therefore in that cases definitely ureter involvement will be there. So pelvic side wall is involvement, hydroureter, hydronephrosis is seen in stage 3B. Stage 3C is all about the lymphatic spread. Stage 3-1, 3C1, 3C2, pelvic lymph node 3C1, para-aortic 3C2. Metastasis is all about 4. 4A is regional, 4B is distant or superficial inguinal group of lymph nodes. So this is all about the cancer cervix, which we have discussed in the first module. We have concluded with the FIGO staging of cancer cervix. So in part 2 of this module, we will be discussing about the treatment modules, right? The treatment approaches which are available according to the staging of cancer cervix, followed by the radiation, the chemotherapy, what is chemo, radiation, everything will be discussed in the part 2 module, right? So please keep studying, students. And then if you haven't subscribed to the Mackler handle, please do subscribe so that you will get the daily video modules which are getting released from our platform. And please try to be active in attending the MCQ sessions which will be released both in Instagram as well as in the Mackler YouTube page.